Hello and welcome to Pathology Central Key Concepts. The topic of this video is asthma. I'm going to begin by comparing and contrasting obstructive and restrictive pulmonary diseases, and I will then review the different types of asthma. Next, we will do a deep dive into the pathogenesis of atopic asthma, which is the most common type of asthma. And I'll finish up by discussing the morphologic findings of asthma, as well as a brief discussion of treatment. So first of all, let's think about how do we measure pulmonary function? How do we know that someone has pulmonary disease? So the tool that we use is spirometry, which looks at inhalation and exhalation volumes related to time. And the two values that we get from this are forced expiratory volume at 1 second, or FEV1, and forced vital capacity, or FVC. Now, I just want to take a moment because not everyone is aware of this, but most spirometers adjust for race automatically. In fact, I do not know of one that does not adjust for race. And this is something that when you are inputting the patient's demographics for the test, it will explicitly ask you what is the patient's race. And there is actually an excellent book by Lundy Braun, Breathing Race into the Machine, that goes over the history of this and the implications. There's also a shorter article that you can read on this topic. So what do we do with these values? How are they useful? Well, they can help us determine whether an individual has obstructive or restrictive disease. So obstructive disease is defined as increased resistance to airflow. And this can be, for example, due to airway narrowing, which is what we see in asthma, due to mucus and airway remodeling. And it's something that we can see in emphysema due to elastic recoil decrease. And the thinking behind what we see in emphysema is that ordinarily the elastic fibers in the alveoli give a little push to that air. If we don't have those elastic fibers because they've been destroyed, you don't have that, and that results in functional increased resistance to airflow. So how do we measure this? If we put a patient with obstructive disease in a spirometer, what we'll see is that the FEV1 is going to be significantly decreased as they're trying to push that air out as quickly as possible. There's narrowing, there's resistance, the air cannot flow out very quickly. We're also going to see that the forced vital capacity is either going to be normal or slightly decreased. So what's going to happen is the measurement we'll be looking at will be the ratio of FEV1 to FVC. And because of the significant decrease in FEV1, we're going to get a decrease in this ratio. And we typically will say that if we have a decrease in this ratio which is less than 0.7, this is indicative of obstructive disease. Now, some of the diseases that we consider to be obstructive are emphysema, as I mentioned, chronic bronchitis, asthma, and bronchiectasis. Now, the next category is restrictive disease, and this can be due to decreased expansion of the lung parenchyma. So you can either have this with healthy lungs but decreased chest wall expansion, or it can be due to interstitial lung disease. So examples of decreased chest wall expansion can be severe obesity, pleural diseases, so thickening of the pleura, kyphoscoliosis, and neuromuscular diseases that prevent a full full inhalation. The interstitial lung diseases include the pneumoconioses, interstitial fibrosing disorders, and infiltrative disorders such as sarcoidosis. And what we see in these patients is that the FEV1 is typically normal, maybe slightly decreased. FVC, so forced vital capacity, would be slightly decreased. But because of this, that this can also be decreased, we have an FEV1 to FVC ratio which is near normal. So with that in mind, let's talk about an obstructive disease, asthma, as a model for obstructive disease. So what is asthma? So it's intermittent reversible airway obstruction, which is characterized by wheezing, shortness of breath, chest tightness, or cough. I am someone who does have asthma, and I can attest to that feeling of wheezing and chest tightness, that inability to fully oxygenate. What we also will see with asthma is chronic bronchial inflammation with abundant eosinophils. And in response to asthma, over the long term, we're going to get bronchial smooth muscle hypertrophy and hyperreactivity and increased mucus secretion. And we will end up with something called airway remodeling, which I'll show you an example of later. Now, for asthma, even though I'll be talking about morphology, we don't biopsy for this. We typically will make the diagnosis based on the clinical presentation, and we can use spirometry with bronchodilators to assess response to therapy. However, asthma it can be, for some people, it can be just an occasional inconvenience. For others, particularly those who lack access to care, who are not able to get appropriate treatment, this can be very dangerous. And with repeated bouts, you may end up with a lack of response to therapy, or even for some individuals, this can happen without a long history of asthma. The term for this is status asthmaticus. The preferred term in the modern era is acute severe asthma, but that doesn't really communicate to physicians the urgency that status asthmaticus does. It seems we all recognize that that means something really dramatic is happening. And what happens is that the typical therapies don't work, and the patient can actually end up dying from status asthmaticus. So keep in mind that while many of your patients will experience this as an inconvenience or discomfort, it can also be deadly. So let's talk about now what we see in the airway in asthma. And before we begin, I'd like to discuss what we see in the healthy airway. So here we can see we have our epithelial layer in the bronchiole. We have a thin layer of mucus, our epithelium with the cilia, which is beating the mucociliary elevator, getting the particulate matter out of the lungs. We have scattered goblet cells, and all of this rests on a basement membrane. In our lamina propria, we have a few scattered inflammatory cells. Those are normal in the healthy airway. We have a band of smooth muscle, and then we have our submucosal glands and a little fragment of cartilage holding everything rigid. In asthma, this thin layer of mucus is now going to become a thick mucus accumulation. It can even become a mucus plug, and I'm going to show you something about that a little bit later. We now have goblet cell proliferations, so instead of just a few scattered goblet cells, we now have abundant goblet cells which are releasing this mucus. We have a thickened subepithelial basement membrane. This is going to be in response to the mediators that are being released by this marked inflammation in the lamina propria. It's a mixed inflammation with eosinophils, macrophages, lymphocytes, and neutrophils. And in long-standing asthma, we're going to get muscle cell hyperplasia and hypertrophy, as well as hypertrophy of our submucosal glands. Now, as you can see here, the bronchial wall is markedly thickened. And the result of this is going to be a narrowing of our airway. There are multiple types of asthma. I'm going to be focusing on atopic asthma, as that's the most common. And this is a type of asthma that is triggered by environmental allergens. Now, the term atopy is something that you'll have seen in the immunopathology chapter of Robbins. And you'll also revisit it when we talk about eczema in the skin chapter. And atopy is basically a genetic predisposition to develop allergic diseases. And individuals who are atopic tend to develop allergic rhinitis, asthma, and atopic dermatitis or eczema. And this tends to run in families, and I'll talk about that more in a moment. Now, there's also non-atopic asthma, and this can be asthma in response to respiratory infections, cold, exercise, inhaled pollutants. I don't know if you've ever gone for a quick run in the cold and felt just that wheezing, that chest tightness. That's non-atopic asthma. Drug-induced asthma can be in response to a variety of different medications. Aspirin is the classic example. As you recall, aspirin will decrease levels of prostaglandin E2, which is going to increase the pro-inflammatory mediators of the variety of leukotrienes. You can also get occupational asthma. So these are going to be patients who are triggered by fumes and organic and chemical dusts. So now let's turn our attention to atopic asthma, because this is mostly what you'll be seeing, particularly those of you who are in pediatrics. So as I said, it is the most common type of asthma, and it is an exaggerated Th2 response to ordinarily harmless environmental antigens like allergens in dust, pollen, animal dander, food, or secondary to infections. And what we'll see is in response to this Th2 response, we'll get a type 1 IgE-mediated hypersensitivity reaction. Again, something that was covered in the immunopathology chapter of Robbins. Typically begins in childhood, and there will be a family history of atopy, which may or may not include asthma. So there may be a family member with eczema and the child who presents with asthma. Its onset is often preceded by allergic rhinitis, urticaria, or eczema. And the diagnosis is made by episodic symptoms which are characterized by airflow limitation, which improves with bronchodilators. So as I mentioned, I had asthma as a child. I did not get spirometry. We didn't do an FVC1 to FVC ratio. Basically, I came in, I was wheezing. They gave me a bronchodilator. I stopped wheezing. They said, you have atopic asthma, and I was therefore managed with that medically. So what causes asthma? So as I mentioned, it is an exaggerated Th2 response, and we're going to get a release of abundant cytokines. And it's not just the Th2 cells that are releasing these cytokines. We also have eosinophils and mast cells that are joining in the party. And because of this, we have a lot of cytokines that are floating around, and they are self-amplifying. So there's a positive feedback loop. So we have IL-5, which is going to increase recruitment and activation of eosinophils. Eosinophils can then go on to release these other mediators. So you have this feedback. IL-13 is going to result in increased mucus production, and IL-4 and IL-13 are going to increase production of IgE by B cells. As you recall, B cells can release different types of antibodies, and this is going to push them towards IgE. IgE, of course, being important in mast cell degranulation. So once you have a patient who's already sensitized for asthma, when they next are exposed to that antigen, we're going to get cross-linking of the Fc receptors on mast cells by those abundant IgE antibodies. The mast cells are going to degranulate, there will be release of mediators, and we're going to get two phases, an early phase reaction and a late phase reaction. The early phase is characterized by bronchospasm, increased mucus production, and vasodilation. And the mediators are histamine, prostaglandin D2, leukotriene C4, D4, and E4, as well as reflex neuropathways. That's going to lead to our bronchospasm. And if you're feeling a little bit lost in the soup of the mediators, remember there is a video on inflammatory mediators. We also have the late phase reaction. So this is going to develop within minutes. This is going to continue to evolve over hours. And what will happen here is these inflammatory mediators are going to stimulate epithelial cell chemokine secretion, which is going to cause recruitment of more Th2 cells, eosinophils, and leukocytes. These eosinophils can elaborate a variety of different mediators, but they can also release major basic protein and eosinophil cationic protein, both of which can cause epithelial damage. Okay, let's look at how asthma is first triggered. We have the inhalation of a bit of pollen, which takes this antigen, which is an allergen, and binds to this dendritic cell, which presents it to our Th2 cell. Our Th2 cell is hyperreactive, and so is going to begin elaborating IL-4 and IL-5. IL-4 is going to take us to the production of IgE producing B cells, and then on to IgE secreting plasma cells, which will be releasing these IgE antibodies. IgE antibodies, when they bind to the mast cell, are going to cause elaboration of IL-5. We also get IL-5 being elaborated by our Th2 cell, which is going to cause eosinophil recruitment. Eosinophils are brought to this area by eotaxin, which is elaborated by our epithelial cells. Now, when this patient who is now primed for asthma is then re-exposed to this pollen, what's going to happen is that these the IgE antibodies are going to now cross-link our receptors on our mast cell, and this is going to stimulate our vagal efferent nerve. We're also going to get, through this damaged epithelium, we're going to get stimulation of the vagal afferent nerve. This is going to come together in our immediate phase, causing bronchoconstriction. Also, in these first few minutes, we're going to increase vascular permeability and edema, so that's going to cause swelling of the bronchial wall. And the mast cell is going to be stimulating the goblet cells to release mucus. Now, in the late phase, what happens is that we continue to have our mast cells being bound by the IgE antibodies. Now we're getting our leukocyte recruitment. Our Th2 cells are elaborating IL-5, bringing in more eosinophils, which are going to be secreting our major basic protein and our eosinophil cationic protein, which is causing damage, as you can see here, to the epithelium. Our goblet cells will be secreting abundant mucus, stimulated by mediators from our Th2 Th2 cells as well as our eosinophils and mast cells. And we also have additional mediators elaborated by our basophils, eosinophils, and neutrophils. This is going to further contribute to our bronchoconstriction. So, once you have repeated bouts of asthma, we're going to get airway remodeling. So if you had just that first instance of asthma, are immediately put on treatment, you never experience asthma again, you will not get this airway remodeling. However, that's not what happens for patients, and particularly for patients who have lack of access to care, they don't get the appropriate treatment. And over time, we're going to see hypertrophy of our bronchial smooth muscle as well as our mucus glands, increased vascularity, and subepithelial collagen deposition. Now, one of the things that we can see, particularly on cytology, is something called a Charcot-Leyden crystal. These are composed of a galectin-10, which is made by eosinophils, and these crystals are pro-inflammatory. So they are going to contribute to our pathogenesis. So what do we see morphologically with asthma? Now keep in mind, we don't do biopsies for asthma. So the features I'm describing are not things that you'll be looking for to make this diagnosis. The diagnosis is primarily going to be clinical. But there are some things that we see, and they do reinforce what we see in the pathophysiology, so I'd like to highlight those. So in cytology, for example, bronchoalveolar lavage, you can see something called a Kirschmann spiral. So these are whorls of shed epithelium and mucus. We can also see these beautiful Charcot-Leyden crystals, which I'll show you in a moment. Now, we don't typically look at the gross of a patient with asthma because we don't do lung transplants for asthma. We don't do resections for it. However, if a patient dies of status asthmaticus, then we will have the opportunity to see those lungs. And what we will typically see in status asthmaticus is overinflated lungs because there's air trapping. The air is not able to make it past these thick mucus plugs. And we can see these mucus plugs grossly, as well as clinically through bronchoscopy, and I'll show you an image of that. Now, the histology is going to reflect the pathophysiology that I just covered. So we're going to see eosinophils, we can see Charcot-Leyden crystals in the mucus plugs, thickening of the airway wall, subbasement membrane fibrosis, increased submucosal vascularity, and increased size of our submucosal glands, goblet cell hyperplasia, metaplasia, and hypertrophy and hyperplasia of the bronchial muscle. So let's begin with a beautiful image of a Kirschmann spiral. This is not pathognomonic for asthma, so this can be seen in other conditions as well as other organs like the bladder, rarely. But I show this to you because this is something that you may well see on a step exam or a shelf exam because it is associated with asthma. So just be aware that here is the actual Kirschmann spiral, and we see some mixed inflammation associated with it as well. Here are the Charcot-Leyden crystals, again with a mixed inflammatory background, very beautiful eosinophilic crystals. Again, something that you may see on an exam because it's closely associated with asthma. Now, what we can see clinically, this is a bronchoscopy showing this incredible mucus plug here in this bronchiole. This is a very dramatic mucus plug. You can see they were able to extract it. It is almost 8 centimeters long. So this is being produced by those goblet cells and why the patient is having a lot of difficulty breathing. Now this is an example of what the lungs can look like in status asthmaticus, and it's shown in this particular view with the chest plate removed because the key feature here is that the lungs are going to overlap the heart. So ordinarily the lungs are going to fall back a little bit. You'll see the lung more clearly. These are full of air, so they're very almost ballooned out because of air trapping. If we were to slice this lung, what we would see would be, again, this mucus plug, which you can see here in this bronchiole. Again, you can see why these individuals have a lot of difficulty breathing. And this mucus plug, let's look at it histologically. This is not a terrific image, it's low power, but you can see, again, this mucus plug that is filling up the bronchiole, and there's some mixed inflammation around here as well. You can't really appreciate some of the other features, so let's look at those on this really nice image from Robbins and Kumar Basic Pathology. You can see here we have our bronchial muscle hyperplasia and hypertrophy. We have abundant eosinophils, a thick subepithelial basement membrane, and then look at all of these goblet cells. And then in the overlying mucus, you can see we have some extravasated red blood cells, and if we were to look carefully, we would probably find eosinophils as well as some Charcot-Leyden crystals. So how you treat patients with asthma, so if it's mild disease, bronchodilator, which can have beta agonists, and it's really quite remarkable. This is one way that we can diagnose asthma. For example, for myself, when I became wheezing, you take a hit off your bronchodilator and poof, like within seconds you can breathe. It's really quite amazing. You can also be given glucocorticoids or leukotriene inhibitors. For patients who have severe or difficult to treat asthma, in addition to these modalities, we can use biologic therapies that target inflammatory mediators such as IL-5 blocking antibodies. I'm going to finish up as usual with some questions. What are the features of early phase reaction in asthma, and what are the features of the late phase reaction in asthma? And then finally, how do the morphologic features correlate with the pathogenesis of asthma? I hope you have found this useful. Please feel free to follow me on Twitter, put comments down below. I sure would appreciate it. Thank you.